On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled, Can You Uncatch My Drift? Dealing with Practice Drift in Healthcare. I'm Susan Wallace, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar. Christopher Mamrol is a Senior Patient Safety Liaison with the Patient Safety Authority for the Southeast region of Pennsylvania. Chris offers an extensive and well-rounded patient safety background to his facilities, with his experience in the behavioral health field, specializing in quality improvement, data management, and facility-wide safety. Chris brings a distinct skill set and viewpoint to the Patient Safety Authority. Prior to joining the authority, Chris worked at Montgomery County Emergency Services, serving in multiple roles, including as a psychiatric technician, registered nurse, risk manager, patient safety officer, performance improvement director, and managing multiple departments as the safety and quality systems director. Chris, I will now turn the program over to you.
Thank you, Susan, and welcome to everybody. Thanks for joining us today. Today's objectives, we're going to talk about drift, identify the signs and factors that contribute to drift. We'll also discuss the impact of drift on clinical processes and outcomes. And then we're going to go over some strategies for reducing or eliminating drift within your organization. So what is drift? Before we get into our objectives, the gearheads out there are probably thinking, oh, it's when we whip around a corner. It's when those reckless drivers go through my neighborhood and slide around and they're drifting. Not the drift we're talking about today. The drift I want to talk about today is really drift away from an established process or procedure, some type of variation, a violation, a deviation from what normally happens. And we'll talk about how that can kind of escalate and get further and further from what should actually happen. I want to start off, I'm going to stick with the cars and just kind of give you an example of drift that we probably are all familiar with. You see this lady here, she's driving, she has both hands on the wheel at 9 and 3. Which of course is the accepted standard now. I know everyone, it used to be 10 and 2, but now with airbags and everything, it's actually 9 to 3. So if you're not driving safely with your hands at 9 and 3, this is your public safety announcement to please do that. You don't want a broken arm from your airbag. But we all know that this is what we do, whether it's 10 to 2, 9 and 3, whatever. We know we're supposed to drive with 2 hands. Think back to the last time you drove, whether it was driving into work today, dropping the kids off somewhere, driving to the store. Did you have both hands on the wheel the whole time? Probably not. Most of us drive with one hand. We're adjusting the radio, the heat, something else, turning on your windshield wipers. It's very rare that somebody sits and has both hands on the wheel for the entire time that they're taking their ride. How about other safety processes? You know, if you look at the manual of your car, you're supposed to walk around and do a safety inspection before you drive anywhere. How many of us are doing that? How many of us are checking fluids? I know we do before long drives. I personally do before long drives and things like that, but it's not something that's very frequent. Is drift a bad thing? In this case, probably not. I think most of us can very easily control a car with one hand. So there's that perception that, yeah, I can, if I drive with one hand, then I'm able to adjust the radio. I'm able to, turn on my windshield wipers, control other elements within my car without really causing too much risk or deviating from safety practices too much. However, the more I do that, the more I deviate, the more I drive with one hand, I can go, oh, okay, well, I'm driving with one hand. I can also drink my coffee. I can eat my sandwich while I'm driving or have a snack. The more and more these things happen, the more I might convince myself that this is acceptable. I'm okay. I can drive with one hand. I can eat while I'm driving. I can drink coffee while I'm driving. I can listen to music. But think about it. The more and more things we do, this is all increasing the risk. So where does drift become unacceptable? Another sign of drift, and I'm going to stick with cars, We have established speed limits on every road in Pennsylvania, and those speed limits are come up. There's series of engineers, and they sit down and they look at, what are the weather conditions in this typical area, the slope of the road, the number of curves, the distance, the surface, and they come up with a speed limit. It's not just arbitrary. It's a very well-defined rationale to establish a speed limit. How many of us follow those speed limits all the time? I'll be full disclosure, I do not. Typically I'm going over the speed limit, whether it's 5 miles an hour over, 10 miles per hour over. I know we do this in person, and I talk about drift, and we might ask, like, how many of you speed? Have you ever gotten a speeding ticket for going over 5 miles per hour over? We've convinced ourselves that it's not that dangerous. In many instances, we convince ourselves that, they won't actually give you a ticket if you're only going 5 or 10 miles per hour over the speed limit. There's no law that says that. There's no law that says that you can't get a ticket for just a slight deviation from the speed limit. They can give you a ticket for going 1 or 2 miles per hour over. But we've established this, not just me, not just the people on this call, but as a society, we've kind of normalized this deviation of going 5 to 10 miles per hour over the speed limit, kind of going with traffic. If you've seen, there was a group of college students, it was a few years ago, probably about 10 years ago now, but they took cars out. They took 3 cars out onto the highway, and each one of them got into a lane, and they drove 55 miles an hour down the highway when the limit was 55. How do you think people reacted to that? I'll tell you, there was huge lines behind them. People were angry because that they were going the speed limit. There was not that normalized deviation, so it was throwing everyone off because we've become so accustomed to going that 5, 10, 15 miles per hour over the speed limit. So is that okay? Again, is going 5 miles over the speed limit much more dangerous than driving at that 55? Probably not. But when does it stop? If driving 5 miles an hour is okay, is 10 miles per hour over the speed limit okay? Is 15, 20, 25? Is going double the speed limit okay? So it really becomes a balancing act of, yes, some drift is to be expected. Some drift it's always going to happen. It's normal. It's a natural inclination. But at what point, and in healthcare, do we need to step in and really address drift? So I mentioned healthcare. I think one of the best examples of drift in healthcare is hand hygiene. And you can see there's some statistics from a WHO study up here as far as, and this was international, as far as the opportunities for hand hygiene and the low adherence. The lowest adherence was in the ICU. Why does this happen? We know that the evidence out there. We know the benefits of hand hygiene, and I feel like we've probably gotten a lot better at this over the past year and a half. In our unprecedented times, but we're still having issues with getting that compliance all the way up. Why? If you've walked into a store, if you remember, a year and a half ago, everything went completely new, completely different, unprecedented. Once we returned to stores, and I went back into a grocery store for the first time, everyone had hand sanitizer stations right at the front of the store. It was great. I'm a germaphobe. I like washing my hands and doing hand sanitizer anytime. I have multiple bottles in my car, by the doors of my house. I make my kids use it all the time, and it's great. So when I would walk into a department store, a grocery store, and there was a hand sanitizer station there, I'd take a squirt and sanitize my hands, and that's great. That really cut down on the amount of illnesses we saw throughout the healthcare system. Are those still full and operating? Most places still have those stations up front. When's the last time you went in and you went to get a squirt of hand sanitizer and that station was empty? Right? It happens. So we have this change. We added all of these new hand sanitizer stations, and when they were first added, the staff was probably real good at checking them regularly, filling them up regularly. And it became kind of a drag. It wasn't as frequent that people were using them because people kind of fell out of the habit of using hand sanitizer maybe. So maybe it wasn't checked as often. Maybe the person that checked it got a new job or worked in a different area, and we didn't replace who was checking that. So I know I can say through my experience, a lot of times I'll walk into a store and those hand sanitizer stations are empty. That's an example of drift. I'm going to use this example, and I'm going to take you through a a couple different steps. This is an example from, it's a graphic published by Betsy Lehman Center from an article by, you can see, it's a study done by Emil Berti. It's a group of French patient safety experts that kind of looked at this system of how we identify drift and how drift happens and put it into a healthcare framework. So I'm going to take you through, and this graphic is a little bit weird, is that we're going to actually move from right to left. So we're going to start on the right side in the so-called legal zone. This is where all groups start. This is, you're doing things by the book. We're following all of our policies, all of our procedures. There's no real deviations from it. So this is no drift. This is where we start, okay? After a while, there's that natural deviation that we're going to start drifting out of the doing things by the book, okay? We might take a little bit of a shortcut. These are things that they're not unsafe. There's still that perceived minimal probability of harm, but there's a benefit to us. So the system's relatively safe, but we might be able to do things a little bit faster. We might be able to do things in a way that uses less material, so we're saving a little bit of money, or we're saving steps when we're going through an EMR or using a piece of equipment. So we start to get these little tiny deviations that aren't that big a deal. And you can see the letters up at the top there, BTCUs. Those stand for borderline tolerated conditions of use. So these are things where we're increasing productivity, but we're not having any effect on the quality of patient care or on safety. This is okay. This is why we call this the illegal normal zone. It's not legal. We're not following the processes. We're not following the procedures. We're violating the policy, yes, but this is where most systems will operate for a long time in that illegal normal zone. Fortunately, the longer we spend in this illegal normal zone, the more we're going to push out towards those last two zones there, which are part of the illegal zones. Once we get here, we're starting to follow deviations that, yes, increase productivity. We see our peers doing something, and we see our peers getting their work done faster, so we start to copy that. We start to mimic it. Maybe we don't have the same rationale for doing it. We're just saying, oh, it's much faster. We don't have the same rationale. We're not aware of why that decision was made. There might be less perception of the actual risk involved there, okay? There might be situations, you can see special circumstances. If we're bypassing some policies or procedures because we're in the midst of a life-saving emergency situation, if we're running around, we're calling a code, we're not going to follow everything by the book all the time. So we're going to do what needs to be done in order to provide that care as quick and as safely as possible. We're still keeping safety in mind, but the focus becomes on that, let's increase productivity, speed, whatever. Saw that a lot. I mentioned what we've seen related to COVID and the extra hand stations and those kinds of things. This is where we start to see the normalization of deviance. And I'll come back to that phrase throughout today's program. But we start to, yes, we're making these deviations. Everyone starts making these deviations. They become habits. They become systemic. We're all doing them. We're all following through on it. And we start to lose that perception of what the risk is. Okay, this is when it becomes a lot more likely that those deviations are going to result in an adverse event or a near miss, something that's going to be recognized. So when we're back in this illegal normal zone, there's small variations. We're not going to see much for it. We're not going to see it come up in event reports or in our monitoring metrics and those kinds of things. It's only when we really push out into the illegal, it becomes normalized that the chance of actually having an adverse event happen increases. What happens when we have an adverse event? We shuffle all the way back to legal, right? A regulatory agency comes in, an accrediting body comes in, and all of a sudden they say, well, you had this event happen because you weren't following your policy. What does your policy say? So now we go back to, okay, we're going to be doing everything by the book. And that's great for a while. Then what happens? We start shifting again and again. It's just that natural tendency to drift. So we need to be aware of that. Why is that natural tendency there? Why? two main reasons I'm going to talk about is the first being individual motivation. We're going to, as an individual, assess the consequences, what the benefit is of each action I'm taking, weigh that against my own feelings, my own morals, my own ethical beliefs, those kinds of things. And I'm going to do what is best for me while at the same time staying within the limits of a safe culture. Those of you familiar with the just culture model, this is where we start to see those at-risk behavioral choices. Things that I'm doing that, yes, are increasing risk, but I'm choosing to do so either because I don't recognize that risk or because I'm justifying that risk as being worth it. I'm saying, well, my ability to increase the speed of this process is worth the minuscule increase in risk that might actually be there. After the individual, which is a huge thing, there's also going to be organizational influences. The main cause we see of this is really when we set goals as an organization. If we set those goals and they're unachievable with our current processes, they're unachievable if we do things the way we're supposed to do them, the only way to get to those goals is to create shortcuts, workarounds, which again, I'll go into a little bit more detail later. For those familiar with the work of James Reason, this is where we talk about where he talks about a vulnerable system syndrome. We might blame things, these deviations, on the frontline workers. The organization itself doesn't really identify the issues. We mask the problem as an organization. We kind of become lax and we allow those violations, that deviation, to occur. There's no events happening because if I'm going to jump back to our goal here, if we're in this illegal normal zone, we're not seeing those variations. We're not seeing the events come up and be reported. So without paying close attention, we're not going to identify that. And if we're not identifying it as an organization, we're going to allow it to happen. So there's no reaction. It's tolerated by management, by the organization, and that drift will continue to occur. So what kind of drift does occur? I'm going to talk about two types. This is practice drift and mission drift. Practice drift, I'm going to give a definition. Practice drift can, in a more narrow view, focus on a healthcare professional working outside of their scope of practice. That's not really the means I'm going to use it. That's not really the definition I'm going to use today. But just be aware that if you're out there, you're doing research, you see the term practice drift, a lot of times that can refer to operating outside of your scope of practice, which is a separate issue, obviously that needs to be addressed. But there's practice drift that doesn't necessarily go outside of your scope of practice, outside of your standards of practice. It's still practice drift. Then I'm going to talk about mission drift, which is more of that organizational drift that's related to that. These two types of drifts are going to be bound within what I'll call three different types of boundaries. You have your workload boundary, what your staff are experiencing, what your staff are developing as far as on an individual basis. There's going to be a financial boundary for all of these. That's going to be more on mission drift than practice drift, but there's a budget limit. There's an activity. There's activities that cost money. So there's going to be constraints based on financial reasons. The last boundary is that safety boundary. And this is, if I go, thinking back to that previous diagram, that's where we're really going to push into the illegal zones is passing that safety boundary. The problem with the safety boundary is it's not very well defined. When we talk about a workload, there's a finite amount of time. When we talk about financials and we have a budget, that budget has a limit. We're either below budget or above budget. When we talk about safety, there's process measures. We have standards of care, standards of practice. There's regulatory restrictions. Your accrediting bodies. We're measuring clinical outcomes, those kinds of things. But we really don't have a hard line where something becomes where that risk becomes acceptable versus not acceptable. So that's important to pay attention to as we talk about this. So practice drift. So when a healthcare worker bends the rules, develops a workaround, or creates a shortcut to accomplish a task or solve a problem. And I put here may include skirting written policies or their scope of practice. Like I said, scope of practice violations, those obviously need to be addressed. when we see these more minor deviations from standard processes, they're not always a problem. Sometimes they're positive, actually. Sometimes, you know, when we talk, I'm a nurse by training. I believe most of you on the call are probably nurses, doctors, some type of healthcare worker. We have training, and that training and a lot of what we go through when you go to nursing school and we practice the science of nursing, there's problem solving there. What do? We're looking at a situation and we're coming up with a solution to that. It's really, really hard to turn that off. So yeah, I might have a policy, but the policy is really outlining steps in a very complex process. And in that very complex process, dealing with the problems that I'm facing on a daily basis, I have to use my problem solving skills. So I've heard it said that if a workaround exists for a problem, a nurse is going to find it. And I believe that wholeheartedly. That's the way we've been trained. We think we're looking to solve a problem. A lot of times the solution to a problem is not going to be the exact laid out policy procedure step by step. We're going to probably find the easiest way to do that. Again, minimizing safety. You know, when we talk about drift, we're not talking about those intentional violations, or I'm skipping something, or I'm neglecting something to you know, really personally benefit me at the risk of my patients. We're not doing that. That's not drift. That's a separate issue that I'm not going to get into. But really what we're thinking about is I'm perceiving this as, okay, this is an acceptable risk. I'm making a deviation. This is an acceptable risk. Again, at-risk behaviors, I'm justifying the risk that I'm taking. Not always a bad thing. I'm going to mention this several times, is that drift isn't always bad. It's going to be, it's really necessary when you talk about high reliability organizations and industries and that system of organizational learning. You need some type of variation in practice in order to learn and grow and identify the opportunities for increased productivity and optimal practice. Okay. But again, keep in mind the perception of risk. So we might not perceive that there's a huge risk, but there may be. So the trick is kind of identifying that on an organizational level and addressing it. So I want you guys to think, this is again kind of geared towards nursing because this is you know my background. But have you ever deviated from the procedure of the safe medication rights? Those 5 rights or 6 rights, 7 rights, 8 rights. I've heard 9 up until this point. But you know, if you've had the same patient for a month, are you checking all of those IDs every single time? Are you documenting that you're giving meds before you actually walk into a room to give it? If you have to waste the medication and you're walking around, you're giving medications out to multiple patients, are you throwing the medication in your pocket until you can find another staff member to witness you wasting it? These are all examples of drift. Are they grievous examples? There's a gradient here, but most of them aren't too bad. They're not blatant. They're not blatant violations that need to be addressed immediately, that we're just putting someone in risk. It's not reckless behaviors, but this is definitely drift, and most of it's not acceptable. The problem is, once I do something once and get away with it, there's no bad outcomes. That just reinforces my mental model of this is okay. This is an acceptable deviation. This is acceptable drift. And if that's not challenged, it becomes normalized. So we get back to that normalization of deviance. If it's normalized, other staff members, my peers might see what I'm doing. They might adopt those behaviors. And then all of a sudden, without that recognition, we start to get to some reckless actions, some reckless actors, reckless behaviors, those kinds of things. Once we have widespread drift, that can be a serious issue. How do we know if we have widespread drift? I'm going to talk in a little bit about some ways to identify it, but really once your drift gets widespread, you need to look at what you have in place that are really identifying your rules, identifying your barriers. So I talked about the financial barriers. Are your financial barriers too strict? Are your practice barriers too strict? Are you not giving enough room for interpretation and variation in those practices to allow for some level of flexibility, which is important? So we're going to see more drift the tighter and more strict your rules are. I mentioned those violations. Most of the time we do those violations, nothing bad happens. It's only really once it happens over and over and over again that the chances of seeing those adverse events or even those near miss events are going to happen. So if we're not doing anything about it before we see those events or before we get to the point where it's happening, across our practice, we're not going to be able to control it. It becomes harder to really cut back on it. It becomes harder to address. So the question becomes, how do we identify it before it gets to that point? How do we identify it before it gets to an event that causes some type of serious harm? One of the ways is looking for those workarounds. I already mentioned if a workaround exists, a nurse is going to find it. We focus on problem solving. We focus on overcoming obstacles. We focus on that outcome focus when we talk about our patient care. So, there's always something different. Every patient is different. We need to have some ability to manage our responses and manage our actions within that. So when we talk about workarounds, they're going to happen. When they do happen, we need to recognize them as a sign that, okay, the system we have in place is not functioning the way we want it to. Whether we need to change the system, to change the practice, to change our policy, it really depends on the type of workaround, the details of it, and what we can learn from those. So I'm going to go through some examples of workarounds. And I'll talk about, what happens in them, what we can learn from seeing these types of workarounds. And they're all very similar with some differences. So I'm going to go into the differences and really talk about how we can use these to identify opportunities. And these do come from an article published from the authority a few years ago. I believe it was 2017, 2018. And that article is available if you want some more details about workarounds and things like that. But we'll cover the basics today. So our first example, nurse was unable to scan a barcode before administering a medication because the barcode was incomplete, outside of her control. The pharmacy was called. The nurse was instructed to type in the patient's name and medical record number and to document the confirmation of the medication manually. So that's what she did. So this is a workaround. This workaround benefited the patient, so it's not a bad thing. It's an acceptable workaround really for what the problem was. We had an incomplete barcode. We needed to give this medication. We found out how to do that. So yes, we benefited the patient. We came up with a good short-term solution, but this in no way addresses that underlying issue of we had an incomplete barcode. The next example, we tried to scan a barcode. The barcode reading indicated that the barcode was invalid. So this nurse spoke with the pharmacy who determined that the medication was not on the formulary. The pharmacy approved overriding the error message and administering the medication. The pharmacy also requested that the event be reported to the facility's incident and serious event reporting system. So, very similar situation here. We weren't able to barcode a medication to administer to the patient. We solved that issue, talked to the pharmacy, they approved overriding it, and we were able to administer the medication. But that second paragraph there is that the pharmacy asked that it be reported. So when we report it, we have documentation all of a sudden. We have that supporting documentation that this issue happened. And if we report this every time it happens, then we start to build up that body of evidence of, okay, we have this issue happening. Even if it only happens, even if it's only reported once, we have evidence that this happened, and we can look at, okay, do we need to address this? How do we prevent future problems from happening in the future? So yes, there was a deviation from our established protocol here. Yes, we did come up with just a short-term solution to this issue, but we took that extra step of really documenting it, reporting it, and helping to eliminate future problems. So this workaround shouldn't need to be done in the future if we fix the barcode issue with non-formulary meds. Last example. After signing out a high-risk medication, RN brought the medication to a patient in respiratory isolation. Once in the patient's room, the patient's bracelet was scanned, and upon trying to scan the medication, an error message was received. The RN discovered that a portion of the barcode was missing, so we have an incomplete barcode again, and that's why the label would not scan. So this nurse gave the medication and then returned to where the high-risk medications were held to scan an undamaged one with a full barcode for documentation purposes. Problem is, when this nurse went to scan the barcode, the scanner indicated that it was not the correct medication for the patient. Did we benefit the patient here? This is a workaround. Very similar. We had an incomplete barcode. We came up with a workaround. We gave the medication. We're gonna scan it later. Even if this is the correct medication, this is an unsafe workaround. This is something that we'll need to address. Is that yes, there might be an issue with the barcode, but if you're going to scan an undamaged one for the documentation, make sure it's the same med, do that beforehand, whatever. In this case, that didn't happen. So this is a workaround that we see that we know we need to address this. Whether we need to address it for, just high-risk medications, do we address it for just patients that are in isolation, under isolation precautions, those kinds of things. We do need to address it. And this is an example of something that increases risk to a point that we're not going to accept that as an organization. So, 3 very similar circumstances. Only in that second one do we really address the long-term problem, which is the goal of identifying workarounds and utilizing that information to improve care. So I mentioned we can have risky situations either in the short term or long term. They can be embedded in your normal patient care. Once workarounds start to happen, again, if I do a workaround once and there's no adverse effects from that, I'm going to justify doing it again. It's going to keep happening. So as that keeps happening and we're not addressing the source of the problem that's leading to me having to do a workaround, we're not doing any investigation, we're not addressing the system at all, that's going to lead to the longer term problems. It's going to be an issue that's not being addressed, and it's not going to be addressed because I found a way to just kind of skirt the problem without fixing it, okay? The other issue, we really want these workarounds to be brought to the front line. We want frontline staff to tell us when they have to do a workaround, when they have to skirt something that might be in our policy, so that we can say, okay, why did we set the policy this way? Is the problem with something on the unit? Do we have issues with our barcodes, or is it the policy that's not correct? Do we need to change when we're barcode scanning for patients in isolation, for example? Do we need to make changes? And really bringing these workarounds and these deviations to the forefront and talking about them with your frontline staff, with your managers on the unit, rather than just maybe your patient safety staff, is important. That's how we're going to accomplish our goals, how we're going to accomplish increasing safety on an organizational level. You see all sorts of things, though. One of the examples I wanted to mention is if you're hiding equipment. If we have, we don't have enough the suture removal kits available in our ED, a nurse might start hiding them. Then when she needs one, it's always available. She has her own little private stash, and I know this happens. We've seen it happen, and how many people have their own little private stashes? And the more people that have a little private stash, or the more items that get put into a private stash, that causes more shortage of that equipment. So it's not only are we not solving a long-term problem, we might be creating new problems if we're not identifying these workarounds and talking about them early along in the process. It's a very, very important, very, very useful tool to really addressing some of the drift that is going to happen. Again, drift is natural. We're not going to avoid it. It is going to happen. We just need to identify it and address it before risky behaviors get incorporated into normal care. So that covers practice drift. I want to talk, it kind of leads us into the mission drift a little bit. Mission drift is a term, it was originally used in microfinance. And this is, we really identify, we know that there's natural shift. We know that this is going to happen. We know that we're going to drift from a defined mission to meet other demands. So if we have a facility, from a healthcare viewpoint, if we're shifting away from dealing with the sickest patients to kind of get more involved in primary care, there's an emphasis there. That's a boon to our revenues. It's going to have financial rewards for doing that. Is it the best thing? Not always. So you can see that third bullet point, results in loss of identity and integrity. So an example, if we work in an academic center, if we're looking away from that mission drift and we're looking towards those financial boundaries and the financial incentives, we might have our practitioners start seeing more patients and doing less research. So we're really getting away of what's defined us as an academic research center maybe. And ultimately, this might lead to a weakening of the organization. We might damage our reputation. We might damage what we're accomplishing from a research basis. So saying that we want to be the best, we want to be the most profitable without actually having a commitment to that, without saying, you know, it's very easy to say, yes, safety is our top priority. In practice, it's a lot harder than that. Saying safety is your top priority doesn't make it so. And frankly, the incentives to emphasize those financial or the regulatory pressures are a lot more than the pressures to maintain safety. And again, that safety, that's kind of a gray area. It's not a very well-defined border of what becomes acceptable risk versus not acceptable risk when we talk about it from a safety standpoint. Okay. Here's an example of mission drift. So we have an anesthesiologist, and we're conjecture here. Apparently from a desire to save money, he decides to reuse the same syringe of Diprovan for consecutive patients. He loudly justified this deviant behavior to the nurses, telling them that the surgical list in the operating room that morning consisted only of a series of short, rapid turnover cases. If you were to use a fresh ampule of Diprovan for each patient, then there would be a considerable cost associated with this practice without any safety benefits. So, is this practice drift as well? Yes, but really it's being driven by that mission drift, by that organizational pressure to save money. We're gonna emphasize our financial incentives over the safety incentives here. Is that, yeah, there might be some risk to it, but we're justifying that. Economy, the financial factor. There's no consequences for the patients. They're short cases, it's no big deal. This happened. We get there, nobody spoke up. So this is an accepted culture, right? So we know that I said this is practice drift. He has an individual motivation. It's obviously easier for him, quicker for him to have one, not open up a new ampule. But if it was just that, he might not go about it because he might say, okay, they want me to use a new ampule for safety reasons. It's best I need to use a new syringe for each patient. But that organizational stress, that organizational pressure, again, for financial reasons, is going to cause some of this drift. It's not always one or the other. It's obviously multifaceted. We're talking about a very complex system when we talk about healthcare. So there's not going to be one easy explanation, which is why I'm trying to separate it into two components for you guys today, is that you want to look at the individual motivation and then that organizational motivation as well. So that mission drift, how do we identify it on an organizational level? How do we have control over it? What are some of the risks? If you have a system of blaming frontline workers, if we never look at our policies, if we say, okay, something happened here because you violated the policy, if you had followed the policy, it would have been fine. Our system isn't the problem, you're the problem. If you're doing investigations and all of your actions are re-education or reorient the worker to policy, emphasize policy again with the worker, this might be a sign that you have some mission drift going on. If we're giving rewards out for productivity and financial measures, if we're saying, I think wait time in an ED is a good example of this. We're doing that for productivity, for financial reasons, for advertising, for PR reasons, we want to have that wait time short. What's happening? What's that telling your staff? Is if you're saying, okay, the main thing we're focused on is that getting that ED wait time down, your staff's going to find ways to get that ED wait time down. So we're going to have the quick fix. We're going to find some ways to get that done faster. I always think about when we think about ED wait times and ways to get it done is back long ago, my high school days, I worked fast food, and if you ever work fast food in a drive-through, you know that there's a time. They monitor. They monitor how long it takes a car to go through your drive-through. Okay, and if our main goal is to keep that time real low, if I have a car comes through and their food isn't ready, I might say, okay, just pull around and I'm going to bring it out to you when it's done. I've seen that happen. I've had it happen to me, getting food for my kids at a drive-through. What is that accomplishing? Is it that much of a harm? No, but it's also taking me out. It's keeping that wait time low because I'm away from the window. They can serve the next person. So it's a quick fix that solves the problem, but are we dealing with the issue of, okay, maybe we're not making the food fast enough. Maybe we're not getting our orders processed fast enough in order to solve that. Again, when it comes to a burger and fries, not that big a deal. When we start talking about healthcare, life-saving measures, and diagnoses and identifying issues like that, it becomes a lot more serious. So really, we need to identify what's happening as quickly as possible. That early recognition is super, super important. How do we recognize it early? We need to have clear processes to identify those deviations and then to elevate it. So that example of the workaround where we're putting in a report. Any deviation that's happening like that, we want brought up. It doesn't necessarily need to be an event report because, like I said, the majority of the time there's not going to be an event that actually occurs, but we need to have some way to elevate those concerns. We need to have somebody in the organization that's looking at how often this is happening. Are we addressing it from a human factors issue? Are we looking at our processes and trying to be proactive in how we deal with things? You can see that reactivity instead of proactivity. So if we're reactive, we're waiting until things get over into that illegal zone and we're starting to see events before we react. And then a lot of times we're going to be driven by regulatory factors. And yes, that'll get us back into that legal zone and everybody following by the book, but anyone that's been in a facility that's gotten, written up or had regulatory citations, we know, yeah, we're going to fix it. Everybody does what they're supposed to with the new process. That goes great for a while. Then, after a couple weeks, couple months, maybe a year down the line, 2 years, we might start drifting back into old habits, or we might start finding new workarounds or new shortcuts to take. So it's important that we want to have some way to identify that before it gets to the adverse events and those kinds of things. The second thing there, the second bullet under the warning signs, the lack of resources. Like I said, it's very easy to say that safety is our priority. Are we setting goals? Are we saying, okay, we're going to get to zero harm, but we're not putting anything in place to get there? That's a recipe for workarounds and drift, because your staff is going to try and do whatever they can to try and achieve that goal that might be unachievable. So how do we eliminate drift? Can we eliminate drift? Probably not. I've mentioned several times is that it's a natural inclination. Is there a way that we can get everyone that's driving to work to have two hands on the wheel at all times? Probably not. If they need to adjust the heat, something like that, there's going to be reason. There's going to always be variation. Sometimes that variation we can learn things. Sometimes we can use that to improve processes. So there's beneficial. So we might not want to eliminate all drift. However, not being able to eliminate it or not wanting to eliminate it is a lot different from not managing it. And that's what we need to do. We really need to focus on ways to manage drift. So how do we identify when we have a setup that might be ineffectual, that's going to require drift to accomplish a goal? We really need to look at, okay, what are our goals? What do we have in place? What are the systems there? And listen to your frontline workers. If the frontline workers are saying, we don't have enough staff for this, or we don't have enough equipment for this, or, this process takes too long, or this isn't really a natural way to go through this policy, use that information. And that's where we can start to see changes and more of that proactivity rather than just reacting to when things finally do go wrong. So, yes, safety reporting, I'll come back to that, but we want that proactive system. So you want to observe if we make changes based on some type of, if we have an event that happens, a regulatory agency comes in, we make a change, we need to observe what's going on with that new behavior. And like I said, it probably is going to follow by the book, be perfect for at least those first couple of days, first couple of weeks, months, whatever. But then there's going to be deviation. Once you start doing something, you're going to start identifying the problems with it. Your frontline staff are going to start identifying the issues with it. And that's really where you need to step in and say, okay, we've seen this. What changes can we make to reduce the need for workarounds, the need for shortcuts? And really, do we need to eliminate these shortcuts, or are these shortcuts within an acceptable boundary of safety? So we're pilot studies and, piloting something, a new process on one unit can kind of help and identify some of these risks right away. I don't want to completely discount the safety reporting. You can see it's the first bullet on there. Yes, it is important, but it's really on the event, and we get very swayed by outcome bias and things like that, and not necessarily identifying the behaviors. So again, back to just culture, you want to look at the behaviors, the behavioral choices that are leading up to different events and those kinds of things, and what can be done to address those. You need to be flexible. You need to be flexible. You don't want to just say you need to follow this procedure by the book. If something happens and you say, why didn't you follow procedure? Maybe a good question. Maybe the better question would be, why did you do it this way instead of what the policy said? And you'll get a reason there. Oh, because the policy said I need to walk down to that room that's, 2 units away, when we have a similar product that's right next door that I can get a lot faster, and it's not that different when I apply it to a wound or something along those lines. So you want to identify those things and give people flexibility within the process while still maintaining that safe boundary. It's difficult. This is not an easy thing. It's something that needs to happen continuously. Very continuously, but you want to have a process. So when we talk about standards of care, standards of practice, the best practices are typically guidelines. We're not having in some instances we might have a bundle or strict process that needs to be put in, but we want to have some flexibility, some of that creativity and that problem solving that we do innately have as healthcare workers. We want to use that. There's a reason we're taught to solve problems and overcome barriers, is that's necessary. There's going to be complexities that we can't anticipate within each process and procedure. So we need to allow for some of that creativity to kind of shine through. And again, the workarounds, I mentioned the creativity, the resiliency, also very important. You don't want to have those ad hoc solutions. You don't want to have to, yes, it's important to have creativity. Yes, it's important to stress our problem solving, but we don't want to have to put our staff in a position where they're having to solve a problem brand new each time. So we want to regularly look at our policies, procedures. We want to include frontline staff and say, okay, how can we maintain safety but also improve efficiency, improve the individual benefits of working through this process? So we want to keep processes as simple, as standardized as possible, while still allowing for as much variation as is safe really in there. Our references for today? No, I'm going to turn everything back over to Susan. Thank you.
Thank you very much, Chris. That was great information. That concludes the slide presentation portion of our program. And we would like now to begin our question and answer period. So if you have any questions, please type them in the Q&A box. That can be found at the bottom of your screen. Just please click on the 3 dots and click Q&A to open the Q&A panel, and then direct your questions to all panelists. And we're going to try to answer as many questions as we can. We already do have a question, Chris, so get ready.
Okay.
And okay, it says, in places where staffing is always subpar, meaning the staff is always exceeding ratios and working short. The person asking is, I frequently hear staff encouraged to, quote, do what you need to do, unquote, to take care of the patients. So she's concerned that this encourages taking shortcuts and risk-taking in all areas. Has this been studied? Any ideas about how to guard against this or to deal with it in any way?
Ooh, that's a good question. And this is when I talk about mission drift, this is what we see here, is that, okay, we might not have adequate staff, we might not have adequate resources, and we're placing that concern, we're emphasizing the productivity. So the do whatever you need to do to get it done is a great example of, okay, we have a mission. Our mission might be to provide, high quality care, high quality and safe care, something along those lines. But is that the mission that we're sticking to, or are we kind of drifting as an organization into we just need our outcomes? We just need to get the work done. Whether we have the staff or not, this is the staff we have. You know what? You guys are problem solvers. Go out and solve it. So as far as has it been studied? Yes, it's not studied probably as extensively as it should have been. A lot of the work that comes from this comes from reporting systems and event reports and things like that. And I think there's some data that comes out of, there's a reporting system in Australia that has focused some on this, but nothing really, when we look at, the no state system, no national system in the United States is really looking at this on a, that pulls up drift and workarounds and is really focusing too much on it as a topic in and of itself. So we have research of how this is contributed to, but nothing that's really saying, okay, this is the best way it's stressed. This is some of what we're seeing as far as outcomes and things like that. Kind of got off topic there. But as far as how to guard against it, it really needs to be at a leadership level. You really need to speak up from a frontline basis and say, yes, we can accomplish this, but not maintaining, not the way the policy says. And do we want to work off policy? No, we want our policy to reflect how we're actually working. So that's something that needs to be looked at by leadership and really addressed, and how we can stay on mission of providing quality and safe care.
Mm-hmm. Would you even suggest possibly bringing that up at maybe a patient safety committee meeting where you have more voice of people talking about it?
Yeah, and again, when you're that's a great place to bring it up, and you do need to bring it up to leadership. But again, involve your frontline staff. They're the ones identifying these workarounds and identifying the shortcuts that are happening, so they have an idea of why it's happening and why they choose this particular path. So it's important, and if you have frontline staff on your patient safety committee, that's a great place to take it.
Mm-hmm. Okay, so we have another question for you, Chris. Can you speak a little more to balancing an environment where you want to foster a spirit of innovation and small tests of change while minimizing drift that would lead to process variation and harm?
Okay, no, very good. So really, I mentioned that variation needs to be there. And if you don't have that variation, you're not going to have as many learning opportunities as you will if the variation doesn't exist. So the best way to balance it, man, if I had figured that out, I'd probably be a millionaire. In I think any industry. But it's really, you need to keep an eye on it, and you need to have good communication with your staff that are testing those little deviations and things like that. You need to revisit your policies and procedures frequently, and say, okay, are we doing this the way it needs to be done? Are we incorporating frontline staff suggestions to improve the efficiency of this? So there needs to be a constant system of communication and a constant system of just reevaluation of what you guys are doing to try and catch dangerous variations early and those good variations as quickly as possible as well, to kind of incorporate them into your standard process.
Mm-hmm. We do have a comment here, and I think this is something we could bring to our leadership. And the person commenting is just saying, it appears this topic could be an opportunity for real-time research for the Patient Safety Authority. So we'll pass that along. And we also had a comment just that appropriate masking is a big drift issue. So those are a couple things that just thought I'd bring up there. Yeah. Let's see what this next question. With capacity at high levels, we are seeing more patients being held in the ED while awaiting bed placement. I worry about increased chance of adverse events the longer this continues. With COVID, the expectation often is do what you need to do to get it done. And I think that that's more of a comment and something that we were just talking about.
Yeah, but you're right. That's obviously a risk area, and you can identify that, and that kind of falls into that unsafe drift, I think.
Mm-hmm.
Yeah.
All right.
I do want to go back to the comment that this is an opportunity for patient safety and real-time research. I agree. Keep in mind, our research is only as good as the information you give us. So if during the course of your investigations, when you're putting in an event report, if you can provide us information about workarounds and things like that, that gives us more data to use for our research and to kind of turn around and present suggestions and interventions for you guys.
Yeah, that's a great point, because we're always looking for topics to research at the authority. So anything that you could provide that would help us in that goal would be great. How can you encourage staff who may be reluctant to speak up to their peers when they notice violations of policies, procedures that can lead to workarounds?
That's a culture issue, really, is that, you don't want someone to be viewed as a snitch or a rat for bringing something up and voicing those concerns. So you need to foster a culture where people will take that feedback. Is if if I'm able to talk to my peer and say, hey, I noticed you kind of did that. Why? Not the, oh, shame on you for you didn't do what you were supposed to do. So it's really, part of it is in the framework of how it's presented from the person identifying that deviation. And then if you have a system focus that kind of, you're not just blaming individuals, then the person receiving that feedback should be more receptive to kind of explaining their actions and taking a closer look at why they might have deviated in the way that they did.
And I think this question sort of touches on that. Do you have any hints as to how to identify practice drift before an incident happens? If someone is out there observing staff, their behavior changes, I think.
Oh, yeah. No, of course. Think about your practices. We can go back to hand hygiene. Does your hand hygiene practices change when Joint Commission is in the house? It's knowing somebody's watching you definitely reduces drift, I think. So really, you need to look at those everyday occurrences, not the special cases, not the events or where something bad happens. You just kind of want to go back and maybe at our staff meeting this month, we're going to talk about how we do medication administration and little things that have come up that might not have been elevated to the point of an event report, or might not have caused risk or done that big a deal, but that we identified in those workarounds. Maybe, oh, we're having issues with the barcodes not scanning properly, and you really want to foster that conversation. Observations obviously are always going to be more beneficial when the person being observed doesn't realize they're being observed. So kind of normalizing that, taking it down to a unit level and encouraging that observation and that peer, I don't want to say peer pressure, but peer pressure is really one of the strongest drivers of minimizing drift and managing drift. How often are staff willing to speak up to their peers when they see those deviations and might see some unsafe practices? And you want to encourage that.
Mm-hmm. Okay, Chris, I think we're about out of time now. You do have a very nice comment in here. It's the person says, not a question, but just to commend your presentation on this topic. Very well spoken and great information to take back. So we're going to end.
Bigger head, but thank you very much.
I want to thank everyone for joining us today. If you experienced any issues assessing the evaluation and our certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar.